I have read that you consider that the effectiveness factors include a strong alliance, therapist self-disclosure, empathy, goal consensus, positive regard, congruence and genuineness, cooperation, repair of alliance ruptures, management of countertransference, accuracy of interpretations of relationship, and encouragement. This is a lot. Is it at reach of the best trained and seasoned or experienced therapist? How do you see this?
Well, listen, to all these qualities, I was thinking I will never be able to have all of them, or at least 50% of them myself. In a way, it's a task of a lifetime.
Yes, it is.
But on the other hand, I would be more positive. That is, as long as you know the psychopathology and you have a good model of intervention, which is tailored to the specific aspects of the different personality features, and then the manualized procedure, in a way, guide you to do something that works. So technique helps very much. And in the context of having a good technique, and of course of being trained to reflect among what is happening through our mind in the therapy process, all these qualities can somewhat be taught and learned through the process of doing psychotherapy under, for sure, constant supervision.
Yes.
So it's a painstaking and really long work, but usually at the end of the training, therapists are able to do something that makes sense, and with good supervision, they can treat with success even some mild to difficult client. And then they learn during the process of a constant supervision in the early years after training. So no, they can be taught. They can be taught, and they can be applied by many of our trainees.
But it requires a very experienced and seasoned therapist and familiar with the adequate model to treat these problems, because I believe that our trainees, they run away from this kind of patients that are so challenging.
My experience is that trainee students would like to treat this patient as long as they are provided with a set of concepts and skills in order to treat with them. I've had many students from basic cognitive training, and they try to apply simple Axis-1 model for depression and anxiety, which don't work, are not effective with these people as used as in the manualized procedure. But when they are taught as to apply them in the context of reflecting in the therapy process, in the context of addressing difficulties in making sense of the mental states, they open up their mind, and very quickly they want to use these strategies and this approach in order to deal with more challenging and difficult clients.
What is for you the most difficult aspect of training beginning therapists to deal with these problematic and complex personality dysfunctions?
It's difficult to say. And what you need is open-minded people. Because if you stick to a specific model intervention, you want to be hyper-technical, I have really no ways to open up your mind. But if you're open and curious, any part of the procedures can be taught. I think that there are maybe 2 or 3 areas which are more difficult. One is you need therapists who are able and willing to reflect about themselves, to give a fresh and open look to their own personal weaknesses. Because every patient with personality disorder challenges us and elicit the most negative features of our life. Negative emotions, be shame, guilty, hurry and willing to cure everyone, and anger and distancing others. So if one is not willing to think about himself or herself, it's very hard. They can be good therapists of people with personality disorders. Then when going to the technical aspects, there are 2 other challenging and very demanding parts. One is a correct reformulation of the underlying interpersonal schema, because you need to recollect material which is often very confused, bits of narrative, aspects of the non-verbal presentation of patients in the therapy, and then try to have yourself a consistent formulation which starts from the patient wish to the procedure, the if-then expectation, the if-then procedures they apply in order to reach their goal, be them attachment or reaching a decent status or belonging to being included in a group. And then they have to assess what is the expected response from the others. Therapists have to assess the expected response of the others and how the patients react. But then it's not yet that easy because self is multiple. So one goal is active, for example, social rank, and I have different and non-integrated underlying self-images. So I can, on the one hand, feel as able to reach good status, but on the other hand, my self-esteem may be very poor in that respect. And the therapist must to able to apply all these elements and find a coherent recurring pattern, which is quite thought-provoking and somewhat challenging.
Yes.
And then another part which is difficult to be taught, and to be applied is when it's the moment in which to push patients for change, because then there is difficult aspects of technique, and in particular often cognitive therapists tend to be too much hasty. They go into a hurry and they push patients
They
for
want to
change.
be effective.
Absolutely. It's like it's your mission, and this is usually don't work. You create struggles, you create strains in the alliance, you feel frustrated, and you push the patient for change. Instead, you have to step down from what you're doing and reformulate the contract.
I see.
And this is, but you must be able to tolerate frustration and build up effective strategies which are very consistent with the case formulation. So having a very solid, crystal clear case formulation and planning your attempts at promoting change systematically around the case formulation is something that requires mind and patience.
And patience.
Yeah.
Wonderful. Thank you so much. I hope we can keep this conversation going.
Oh,
Thank
thank
so
you
much
all the
for coming
same.
to visit us.
Thank you.
Wonderful.